Thank you, Sudhayakumar, for taking up this topic. I don't have to explain in detail the importance of hypertension in pregnancy. As you heard in the pre-lunch session, we have been auditing maternal deaths in our state. Sadly, hypertension contributed as the second commonest cause of maternal death in our state. And unfortunately, what is now happening is it is taking over as the leading cause. Because the erstwhile leading cause, that was hemorrhage, we have a better way of controlling it now. And in the last 3 years, I would say that hemorrhage has gone down from the top, but hypertension is maintaining its position as the leading cause of maternal death. There are of course, other reasons. Sadly, suicide is competing with hypertension as a major cause of maternal death. So the importance of hypertension for the obstetrician, you can easily imagine. And I am sure we are eager to hear from you about hypertension as a problem, as acute hypertension as a problem in pregnancy. Thank you, Sudhay.
Thank you, sir. Let me thank Dr. James, Dr. Sumesh, Dr. Sunny for giving me this opportunity to interact with you all. All the talks previous, you learn from them. Here I am going to learn from you people. Don't ask too many questions to me. You can ask questions to sir, they will answer. And going through this thing, I found that the previous talks were a little more difficult for me. And probably likewise all those things are not very common, not a very simple thing. Thrombocytopenia also, all those things are not very simple. But hypertension is very common for the obstetricians, common for the physicians. So I think there is nothing much new in this. So don't get disappointed if I am not giving an excellent talk. I will tell present certain things which I know. That is in pregnancy, what is the role of hypertension, what are the issues. I was not good in obstetrics and gynecology during my MBBS. Sridevi is my close friend, classmate. Okay, she used to teach me during my MBBS the point which I had to learn to get through in the examination. And the chances are helping me to pass the gynec subject during my MBBS. Okay. Now, these are the 4 questions which have been addressed to me by the organizers. Is it pregnancy-induced hypertension? All of you know. Is it pre-existing hypertension? All of you know. With drugs are said, you should know. Okay, so that part is over. Second is what to do when ACE or AR. You know, it should not be given, so it has to be discontinued. Then hypertension during urgency and emergency, you are tense. So we will call us physician or the cardiologist to manage hypertensive urgency or emergency. And when to use IV drugs, seldom we have to use that drug. So the topic which has been allotted to me is very simple and you know everything about that. But we have postgraduates here. Sir, postgraduates? You have organizers, you have postgraduates here. Then I request the postgraduate to answer my first question. Okay, can you answer better? What is the normal blood pressure? The question is very clear, what is the normal blood pressure? Okay, and I usually tell that if a postgraduate can answer this to my satisfaction, I will give them distinction. And this is the simplest question also. Okay, because then when you define hypertension, you should know the standard guidelines is for adults above the age of 18 years. And we are talking only the systolic and diastolic hypertension. We are not talking about the mean arterial pressure. We are not talking about the pulse pressure. And we are giving a range which is modified a lot now. But this is the important thing. The measurement of the blood pressure before documenting hypertension. I don't know how many of us will be doing this. The patient will be relaxed for 5 minutes at least. Obviously not possible. because they are irritated by the waiting there. We are also irritated. They get in, within a short time we record the blood pressure in supine or whatever percent. So this is very important. This is important thing. In pregnancy, it is very important in the early part, because you are going to diagnose hypertension in pregnancy. It is entirely different from hypertension in any other setting. Two situations where hypertension is very important. In children, it is extremely important. In pregnancy, all other situations, I think we can take your own time. So it should be seated position, and the arm should be at the level of the table like this, and the BP cuff, not the apparatus. നമ്മളെല്ലാം കണ്ടിട്ടുണ്ട്, ബി പി എടുക്കാൻ നേരത്തെ അപ്പാരറ്റസ് പൊക്കി കൊണ്ടുവരും അറ്റ് ദ ലെവൽ ഓഫ് ദ ഹാർട്ട്. അത് നമ്മുടെ കൺവീനിയൻസിന് വേണ്ടിയാണ്, നമുക്ക് കുനിയല്ല. ബട്ട് ദ പോയിന്റ് അറ്റ് വിച്ച് യു ആർ റെക്കോർഡിംഗ് ദ ബ്ലഡ് പ്രഷർ ഷുഡ് ബി അറ്റ് ദ ലെവൽ ഓഫ് ദ ഹാർട്ട്, because it is a zero level. So we are saying that it is 120 millimeters above the center of the heart. The center of heart is taken as the zero level. For any pressure, you have to calibrate or take the baseline or the zero level. The zero level is the center of the heart. Whatever you are talking is from the center of the heart, it is 120 or 130 millimeters above. So the cuff where you are recording, that should be at the level of the heart. That is why keep the hand like this on the table. The leg should touch the feet, touch the floor, and the leg should not be crossed. The patient should not talk. But we will be talking to them. They are forced to talk. Because when we are recording the pressure, we will be asking so many questions. Or they will be answering or taking so many things. They should not talk. These are the important things in this thing. That is a sequence which I have shown. Okay, you should be quite relaxed. Okay. Now the terminology is in hypertension. And obviously we say hypertension. Is it intracranial hypertension? Is it hypertension related to the cardiovascular system? Is it pulmonary hypertension? Is it portal hypertension? So many things. So the correct terminology is systemic arterial hypertension. Because when the venous pressure goes up, we call it as systemic venous hypertension. So the correct physiological terminology for hypertension, which we need not bother. But academically, because postgraduates are there, systemic arterial hypertension, unless specified, when we say hypertension, we imply it as systemic arterial hypertension. The next question is it primary or secondary? And secondary hypertension, we don't evaluate nowadays. But when the blood pressure is not getting control in general population, because we have physicians, obstetricians, general practitioners, everybody. So if the blood pressure is not getting control, you have to look for secondary, the commonest secondary hypertension organ, because OSA can produce hypertension, extreme salt intake, non-compliance can make it resistant. But primary aldosterone is not uncommon. So nowadays, if the blood pressure is not getting control with 2 or 3 drugs, I am not talking about even the resistant. Even hypertension, especially in a relatively young person, we are supposed to evaluate for hyperaldosteronism. Hypokalemia need not be there. Okay? Then resistant and pseudo-resistant. When the blood pressure is not getting control with the standard dose of 3 drugs, optimal dose of 3 drugs, then we call it as resistant. Or when the drug, you get a patient where the blood pressure is controlled with 4 drugs, that also is resistant. Pseudo-resistance is because of other factors it is resistant, or from our side, or from the patient side. Then white coat all of us know, that is when the patient comes to us. But you may not be familiar with master hypertension, which people like me may be experienced. I am comfortable in my hospital. And at home, we have a lot of issues. So home BP, okay, I think all of you agree with that. Okay, home BP is likely to be more than the clinic reading. Ordinarily, clinic reading is more or home reading is low. So that is mass hypertension. Okay, then obvious and home BP, and the more important thing is ambulatory BP monitoring. So you record the blood pressure continuously for 24 hours. You will be doing normal activities. Avoid undue exertion. Your routine activities, not extraordinary activities. Routine activities, you are recording the blood pressure. Every 15 minutes it will be recorded and plotted. And you find that the night blood pressure will be lower and it should come down. We call it as nocturnal dip. Certain people on ambulatory monitoring, the BP doesn't come down. And occasionally it may rise, which has a very bad prognosis, high risk case. So ambulatory blood pressure recording is useful. When you find office BP recordings are fluctuating, or you find the BP is not getting control, or the patient has paroxysmal hypertension, or unexplained things, we go for ambulatory BP monitoring. Okay? The terminologies and the definition and this thing, we follow JNC 1 from 1982. The latest is JNC, Joint National Committee. That is the recommendations or the definitions. Adults, the normal blood pressure is considered to be 120/80. That is normal for an adult. Pre-hypertension is if it is less than 140/90 and between this, that is pre-hypertension. 40/90 or more, documented in multiple sitting, not a single reading. When you have diagnosed hypertension, if the blood pressure is 140/90 or more, it is hypertension. And up to 160/100, we call it as stage 1 or maybe mild. 160, more than 160/100, we take it as stage 2 or severe. In pregnancy, it is a little different. Now, this is the latest terminologies for hypertension. Non-elevated blood pressure. Not, they won't use the term normal because there are a lot of differences between US and European. Non-elevated blood pressure, the systolic blood pressure less than 120/70. I will concentrate on office BP, which we are following, 120/70. And from 120/70 to 140/90, this pre-hypertension is taken as elevated blood pressure. We don't label it as hypertension because once you label it as hypertension to them, psychological impact occurs. So psychological impact occurs when you label them as hypertension. So you say the blood pressure is elevated. And hypertension, as we have said, home reading, the baseline normal or non-elevated is same, but all others, it is 5 millimeters less. And ambulatory BP monitoring still 5 millimeters less. So you can remember this thing and reduce 5. You will get the home BP recording and ambulatory BP recording. So definition of hypertension in pregnancy, it is same. There is no confusion. Blood pressure systolic equal to or more than 90 or diastolic equal to or more than 90 or both on multiple readings. That's very obvious. And mild is taken as 160/110. Am I right? You agree with that? Because I have taken the cardiology books and the cardiology recommendations. 160/110 diastolic is taken as mild, and severe is more than 110 diastolic. Okay? And the literature varies regarding this percentage. You can say roughly 10% of pregnancies are complicated by hypertension and 3% by eclampsia and pre-eclampsia. You can modify it. This figure is not tallying with your values. The classification also all of us know, or all of you know. It is chronic hypertension means the patient had blood pressure documented before 20 weeks of gestation and it persists beyond 6 weeks of postpartum, which I think is equally if not more important. And gestational hypertension is diagnosed for the first time after 20 weeks of gestation and it should resolve by 6 weeks postpartum. That is gestational hypertension. The second part was new to me. Pre-eclampsia, I think all of you know. Eclampsia, you know. And unclassified is you have recorded blood pressure for the first time. Very unlikely. But occasionally when I get a patient may record hypertension for the first time after 20 weeks, they are not sure whether it is gestational or pre-existing detected at that time. Then that is one. Second thing, you have pre-existing or chronic hypertension and they may develop pre-eclampsia. That is included in the unclassified one. Now, pre-eclampsia, I think I should not spend too much time, but there are certain people who are not familiar with this thing, not the obstetricians. Now, it is the proteinuria. Proteinuria is more than 300 milligram in 24 hours. We don't do that. It is a spot urine where you take the protein creatinine ratio, PCR, which is more than 30 milligram per millimole. And the albumin creatinine ratio more than 8 milligram per millimole or more than 30 milligram per gram of creatinine. That part I think I don't know whether everybody is familiar with that. And the question will be why is PCR and ACR which is more important? Obviously ACR is more important because we are looking at albuminuria. There are other proteins which can be excreted in the urine. So we are going for definition of preeclampsia is albuminuria. Am I right? We are going for albuminuria. I am just checking because I have not given or no much academic interaction with the obstetricians, only attending the calls and clearing the cases. So albumin creatinine ratio, it is expressed in milligram of albumin per millimole of creatinine. The other, usually the expressions could be different, so you should know about that. Now there should be maternal organ dysfunction, which all of you know, acute kidney injury, liver dysfunction, which was discussed, hematological abnormalities have been discussed already in the previous topic, and uteroplacental dysfunction, the fetal growth retardation, and abnormal umbilical artery Doppler. That is what happens in, I think we'll come to that. It is a resistance to flow of blood to the placenta. That is one of the major components that can be picked up nowadays by doing ultrasound and Doppler studies. That is the pulsatility index. To the postgraduate, I interact with the postgraduates, and they are less likely to respond. So you take as a homework, what is this pulsatility index? Okay. Can I ask questions to postgraduates? Obviously, they will not raise the hands. Okay. It is you do the Doppler study, you have the Doppler study here. This is the Doppler umbilical artery velocity, the peak velocity minus the lowest velocity, and take the mean velocity. Okay. A high pulsatility index means there is a resistance to flow across that vessel. There's a basic thing in eclampsia, pre-eclampsia. So this all of us know. Pre-eclampsia, you have the various organs which are involved. We are interested mainly in the heart, hypertrophy, pulmonary edema, ischemic heart disease, all those things. And the most important is the pulmonary edema. Now, then you have the respiratory system, which was already discussed, the liver, you know, then the blood components you have discussed, all those things I think all of you know. You know these things. What is the pathology in pre-eclampsia? There is hypertension. The primary event is abnormal placentation. And the most important thing is the remodeling of the spiral arteries going to the placenta, this my uterus. This is the spiral artery which is normal, which is a small layer of smooth muscle confined to this region only. And what happens is the spiral arteries become more prominent. It extends. The circumference or the thickness of the spiral arteries increase. That is a basic thing which is happening in any arteries. In systemic hypertension, pulmonary hypertension, whatever it is the smooth muscle which determines the resistance to flow through that vessel. That goes up, that is called the spiral artery remodeling. And this leads to the placental ischemia, release of the antiogenic factors, which I think the previous speaker or the hematologist have discussed that. And that is what is happening. Normally, the smooth muscle, that is the media, is relatively thin and it stops well before the approximation of the placenta. Whereas here, it becomes thicker and it extends distally. So there is a big length across which the blood has to flow. The resistance circuitry is high, so they develop placental ischemia. So these are the things. There are factors which improve the placental circulation or the flow. That is vascular endothelial growth factor, the growth factor 8. This maintains the placental endothelial health, so that the vessels are dilating adequately, resulting in adequate flow. And what happens is there will be placental excretion of excess of the factors which are anti-endothelial or opposes the action of these drugs. These are tyrosine kinases, endocrine, all those things. This inhibits the action of this vasodilatory or the molecules which improve the endothelial function. So that is one of the basic things which results in what is called the endothelial dysfunction. The placental abnormal placentation, the basic thing, the endothelial dysfunction contributing to the multi-system involvement. That is eclampsia to my information. So all of you know the maternal complication because I have to talk something. It is eclampsia, it can progress. We have discussed about HELLP syndrome, the neurological complications of stroke and intracranial hemorrhage, The cardiac is acute pulmonary edema, acute kidney injury, then the disseminated intravascular coagulation and liver rupture rare. And the fetal complication, the growth retardation, premature delivery, the placenta, abruptio placenta, and hypoxia stillbirth and the fetal loss. The investigations also, as the previous speaker said, you know all these things. The basic investigation, and the question was about electrolyte fibrosis, when it should be done. It should be done, I think, at least once in pregnancy, and whenever there is an indication for dyslipidemia, which may be symptomatic or treatment related. Because when you are treating the patient, the iatrogenic problems can occur, and if you use a drug which is likely to create an iatrogenic problem, for example, when you are dealing with hypertensive emergencies, cardiac acute pulmonary edema, we will be giving aggressive diuretics, which can produce electrolyte imbalance. That's extremely important in hypertension management and maintaining the homeostasis. Then proteinuria, I have said, and specific investigation for hypertension mediated organ damage which we discussed. For the brain, nothing special because it is clinical. For the heart, ECG echo. For the kidneys, you know that. Liver, obviously, you will be doing the liver enzymes in hypertension. When to treat? All pregnant women with hypertension or blood pressure equal to or more than 140/90, if it is persistent, you should treat. And the target is blood pressure systolic should be less than 40 and diastolic should be 80 to 90, maybe 85 and not below 80. Below 80 is not good for the fetus. Okay, that's the way you look at it. If the blood pressure is normal, you just serial evaluation. If it is touching say 150/85, you should be more careful. That is, the BP evaluation should be more frequent. If it is 120/80 during each visit, you can do. If it is touching the upper limit like 135/85 of its readings, if the home BP reading is 135/85, it is abnormal. But your hypertension management in pregnancy and otherwise is based on office recordings. So office recordings we take 140/90. If it is more than 160/110, is it severe or not? No. Optimize the medical management and investigate. If it is more than 160/110, it's an emergency. So we have to be very aggressive in management. So now we come to the next part, what is hypertensive emergency and hypertensive urgency. Emergency and urgency, the blood pressure is still higher, more than 180/120. Emergency means there is an acute organ damage. Acute organ damage is usually brain and the heart. Pulmonary edema, intracranial problems. Acute kidney injury, I don't know. Usually seldom occurs. But these are two acute emergencies. They are life-threatening and your goal should be to control the blood pressure within 24 hours. So obviously you require IV therapy, but that was the last part. When will you give IV drug for hypertension? When it is more than 180/20 with organ damage or acute organ crisis like intracranial or cardiovascular dissection. Cardiovascular include dissection, acute pulmonary edema, and acute coronary syndrome, myocardial infarction. You have to bring it down. That's an emergency. Urgency, the blood pressure is high. There is no acute organ damage, and it is not life-threatening. Okay, blood pressure is very high. So you have to bring down the blood pressure over the next 1 or 2 or 3 days, and it should be by optimizing the oral medication. Okay, hypertension emergency, I said, acute, rapidly evolving organ damage with high blood pressure. I think I have come. The term malignant hypertension is not used nowadays. But examination, they may ask them, I call examiners a geriatric examiner like me, who is now not common. They may ask you about malignant hypertension. And malignant hypertension is severe hypertension with papillary edema. That is what we have to tell. But malignant hypertension is hypertension with target organ damage. Okay, but for examination, it is hypertension with papillary edema. So that is not used nowadays. This is hypertensive encephalopathy emergency. It can affect the central nervous system. It could be encephalopathy, intracranial hemorrhage, grade 3/4 retinopathy, kidneys, acute kidney injury, and microscopic hematuria. Usually, acute kidney injury is not that common, whereas the vasculature is aortic dissection and heart. That's the most striking thing. They come with acute pulmonary edema, myocardial infarction. Dissection, we miss dissection. And incidence of dissection is a little more in hypertension, in pregnancy, and if the pregnant woman is a Marfan, you should be careful. Because we get Marfan syndrome also without gross features or gross cardiovascular manifestations baseline. A Marfan with hypertension, you should be extremely careful. The risk of dissection is more. Okay, these are the drugs. That was the next question. What are the drugs? The oral drugs, all of you know, Levodopa, then you know the dose. I need not. And it's not easy to remember the dose. I think you can get this in your mobile. Because I don't want you people to remember the dose because it is there in your mobile app. Labetalol, 50 milligram BD is what we usually start, and we increase to 100 milligram BD because what we require in my cardiology practice, the dose required for many drugs is half of what is given in the literature. The literature is all Western population. So we can start with 50 milligram twice daily, and then it can increase to 100 milligram to 400 milligram twice daily. Seldom, I don't know whether you have used 400 milligram. Probably you might have used 100 milligram BD, maybe occasionally 200 milligram BD. It is not BD. I think that's a question which I ask because I usually entertain the students by funny questions also. Do you know the full form of BD? Okay. It's not BD. It's actually BID, TID, QID. Okay. BID is bis in day. That is half of a day. TID means tertian. Okay, I'm not telling you because I usually interact with everybody. Tertian in day, quarter in day. But BD cigarette matching the samay. OD chadi matcham. OD is omni day. Okay. So still that is used BID. Nifedipine sustained release we don't have, but what we have is nifedipine slow release or immediate release. We can use 10 to 20 milligram, go up to 20 to 40 milligram, which is very easily available, very cheap also. And sublingual nifedipine should be avoided as far as possible because the heart rate goes up suddenly. When the heart rate goes up, it is unfavorable for the heart and blood vessel. And hydrolysine, it's costly. 25 milligram twice daily can be increased up to 100 milligram daily. And the intravenous drugs which are available to us are hydrolysine and labetalol. The dose, a bolus dose followed by infusion. The dose is there and the infusion is also there. And easily available is intravenous nitroglycerin which we use for acute pulmonary edema because it has so many other actions in the heart also. Acute pulmonary edema, we can bring it down, titrate it by easily intravenous nitroglycerin. Nitroprusside is contraindicated. Nicardipine is not available to us, intravenous nicardipine. So basically for us, I think hydrolysine is available now. Labetalol is fairly freely available. And another issue which was asked to be addressed was, which are the drugs which are safe? Hydrolysine, methyl-dopa, there is no controversy. Dihydropyridine calcium channel blockers should be continued before labor. That is the nifedipine. Dihydropyridine is nifedipine. The other is benzodiazepine, that is diltiazem and verapamil, which bring down the heart rate. So the calcium channel blockers should be discontinued well before labor because they weaken the uterine contraction. It's a calcium antagonist. It reduces the muscle contraction. Beta blockers, atenolol not preferred now. Propranolol should not be used. Metoprolol preferred. You can use bisoprolol or nebivolol, but metoprolol is the standard drug if the heart rate is on the higher side. If the BP is high, if the heart rate is high, prefer labetalol or preferably you can use metoprolol. The drugs which cannot be used, the AC inhibitors, it's very clear. AC inhibitors, the risk is the risk of fetal hemorrhage. That's the important thing. There is risk of fetal hemorrhage with ACE, ARB, ARNI, obviously the new drug may not. ACE, I think it's the full form, angiotensin converting enzyme inhibitors, angiotensin receptor blockers, and another drug which we are using is ARNI, that is angiotensin, I think it is for the physicians, okay. Diuretics increase the risk of fetal wastage because diuresis, the fluid will come down, the placental infarct, then miscarriage, stillbirth. So diuretics should be avoided, but careful use of small dose diuretics is useful in controlling the blood pressure because a combination with diuretic produces a better control. but it's not a first line drug. When you use two drugs, it is not an emergency or urgency, and the BP is not coming down. You can use very small dose of diuretic. And propranolol, bradycardia, low birth weight, all those things. And fortunately, propranolol is not in our pen tip nowadays. We have only metoprolol, bisoprolol, and all those things. Sodium nitroprusside is contraindicated. So IV drugs, it is nitroglycerin for pulmonary edema. Just to finish. Eclampsia, pre-eclampsia with the impending eclampsia, and hyperensive emergency, as I have told. So these were the questions which I was asked to address. Have I discussed pregnancy-induced hypertension? Pre-existing hypertension? I have, I think I have. Which drugs are safe? The last slide shows that. When AC inhibitors become pregnant, stop that and change to some other drug. Hypertensive urgency, bring down the blood pressure over the next 1 or 3 days. Urgency, bring it down with IV drugs. When to use IV drugs? Emergency, pulmonary edema. Thank you so much for the patient listening. And to the organizers, I think I have answered all the questions you have addressed to me.
Thank you, Dr. Sudhayakumar. This is a very good overview of hypertension as a problem in pregnancy. And one thing that struck me was from our undergraduate days, we were told about the BP apparatus should be at the level of the heart. Now only I realize it is not the apparatus, it has to be the arm should be at the level of the heart. Very good, thank you. Alpha methyl dopa, I don't know how many of you obstetricians as well as physicians now use in our state. For a while it was not available. Are you getting it freely now? It is available. We are getting it. I think probably the safest, simplest, and the first line for hypertension, I would put it like that, rather than going to the calcium channel blockers or more than that, labetalol. Labetalol, one thing people forget is that it is an alpha and beta blocker, where the beta blocker activity is more. So it is not as simple. When we are not using other beta blockers, here labetalol also has to be taken with reservation. But people have forgotten about the alpha methyl dopa when labetalol came in. I don't know whether there was a lot of manipulation behind it, but anyway, alpha methyl dopa, with all the bad publicity about it, I'm sorry, about its effect on the liver, about depression and all that, I think is relatively meaningless. We have to still consider using that. That's what I thought. Hypertension is an emergency. The problem is when it affects or causes intracranial problems. That is what the obstetrician is most worried about. Eclampsia as such need not cause that, but hypertension can. So, and again, the relatively late recognition about the Press syndrome and all this. Would you like to comment on that?
I think Dr. Maswin was there in the morning. You could have addressed that to him. I'm not familiar, sir, because
I was not here in the morning when it was mentioned, actually. Yeah.
So because I've not faced that. Okay. So unless you face the issues, it is difficult to answer many questions. Second, pregnancy, all those things, my literature exposure is limited. So we can ask them. We have
No, I was just mentioning the importance of, as hypertension as an emergency, we are most concerned about that way. That's all that I meant. Okay.
But I think your experience, I would like to know, you get more called for the neurologist or to the cardiologist in hypertension, pre-eclampsia, all those things. We get a lot of consultations.
Now that in your side, specialization has happened, most of the time it goes to the neurologist and not to the cardiologist or the general physician.
So thank you for the excellent teaching session. As usual, you have proven that you are a good teacher. Sir, have you ever come across with difficulty in controlling the hypertension pregnancy with all of these drugs?
Not really, sir, because I'll tell very frankly, because now, considering my geriatric aspect, I have brain dynamic cardiologist, all the calls are attended with. There is a problem. So nowadays I get a call for surgical clearance. Now that the cesarean requires cardiology clearance, PPS requires cardiology clearance. So anything for that simple things I get the consultation. Regarding the emergencies, my colleagues will be dealing. So I did not have much experience with uncontrolled hypertension, but it is relatively less because whenever there is a problem case, they discuss with me. So far in the last 1 or 2 years, I don't have in my hospital. I did not have any situation where we had a resistant hypertension in pregnancy. And so far we did not have a dissection. There are a few cases of acute, not pulmonary edema, near pulmonary edema coming to us, which we could manage. And 1 or 2 cases of myocardial infarction in pregnancy. These are relatively rare.
Sir, many times when a pregnant lady comes to your consultation room, I am really confusing whether the cardiovascular system is normal. Because most of the time they will be having the exact signs and symptoms of cardiovascular system involvement, just like tachycardia, palpitation, effort, dyspnea, syncope, like that. Moreover, once the patient went into hypertension, again it will be more confusing. And apart then, when the patient with undiagnosed hypertension went into pregnancy, the first and second trimester, they may found to have a normal BP because of the low peripheral resistance. So is any clinical tool at the bedside to say that this lady is normal or abnormal?
Clinical side, your problems are one, detected high blood pressure during pregnancy.
So most of these patients will be having all the symptoms and signs of cardiac
Okay,
disease.
that is simple.
Second is undiagnosed hypertension coming into the pregnancy, first and second trimester, they may have found to have normal BP because of
First and
normal BP. Because of first and second trimester, because of the low peripheral resistance. Undiagnosed hypertension.
Undiagnosed hypertension, detected hypertension during pregnancy.
And it was not detected prior to the pregnancy.
Okay, that is unclassified.
Unclassified.
Unclassified hypertension. But then that's a different thing. Because there is hypertension pregnancy. Whatever is the definition, you have to go for urine, albumin, all those things and see whether it is pre-eclamptic, gestational hypertension, pre-eclampsia, or pre-existing chronic hypertension with pre-eclampsia. That part is okay. The other thing is hypertension is a hyperdynamic circulation, mimics heart disease. So mimics heart disease because they can have palpitation, they can have breathlessness because of the hyperdynamic circulation and elevated diaphragm, the abdominal distension, all those things. And primary it is more because they are very anxious also. How to diagnose is one, the symptoms we classify into class 1, 2, 3, 4, up to class 1. Mild exertional breathlessness, no problem. Palpitation, if we take what we look at the palpitation, I think we had a discussion on arrhythmias in pregnancy by Dr. Natarajan in the morning. So, is it an episodic palpitation? What we want to know is it an arrhythmic palpitation or a non-arrhythmic palpitation? Suppose the patient says, it's okay. So pre-pregnant and now she says that is normal. Whereas the patient say, the lady says that then you have to see where is an arrhythmic palpitation. I think Professor Natarajan might have discussed the risk of arrhythmias. Pregnancy is an arrhythmogenic situation also, but not major. Then the third dyspnea is there, the pulse. It will be relatively high volume, but the pulse pressure will be relatively normal. The systolic pressure will be upper limit of normal. The diastolic pressure may be a little lower than normal. JVP seldom you look. I don't know anyone will look into the JVP nowadays. You can ask the physicians and even to the cardiologist. Okay, JVP will be elevated in pregnancy. The precordium will be dynamic. There can be apparent cardiomegaly. The spasm can be loud. You can have murmurs. Diastolic murmurs you have to look for cardiac. So it is a comprehensive evaluation of the clinical, which nowadays people do not concentrate much. But I think whenever a patient has dyspnea or you refer a patient to the cardiologist, obviously echo will be done. You will not send a patient, a pregnant lady, not patient, pregnant lady coming to the cardiology opinion for an evaluation, whether from the lady's side or from the obstetrician side, we will do echocardiogram. So that part can be sorted out.
So one more doubt. So suppose a pregnancy is a procoagulant stage, During that time, the patient developed hypertension with AF. Separate from the selection of the anticoagulation, charts 2 score, is it really applicable or anything will be added?
I think the question is not clear.
Patient hypertension with AF.
Hypertension with AF.
And pregnancy is a procoagulant state.
Okay.
So development of selection of the
Antibiotic. Okay. Regarding that is the drugs, we look into that. Regarding the DOAC, the newer anticoagulants. These are not preferred in pregnancy. The usual problem, which is a big topic as such, whether a pregnant woman or a lady can become pregnant on anticoagulant, what should be the schedule? That's an important thing. Then anticoagulation, vitamin K antagonist is not an issue at all, but it's difficult to manage. Difficult, you have to monitor that. It's a hypercoagulable state, so it is better go for vitamin K antagonist. But now you have data on the newer drugs also. Regarding heparin versus low molecular weight heparin, you can use low molecular weight heparin. Because continuous use of heparin is not preferred because of the HUT, which has hit heparin-induced thrombotic thrombocytopenia. And the thing which you have to do before pregnancy, you have to switch over. That is, the drug, oral drug has to be stopped, and you have to switch over to either low molecular weight heparin or unfractionated heparin. That is, aspirin with anticoagulation is the second thing in pregnancy. That again depends on what is the coagulable state. Pregnancy as such is not an indication. But people have shown that even otherwise, you recommend patients at high risk of preeclampsia, you may give aspirin. Sir is looking at the watch here also, it is 002.